لأن عندنا النهاردة سيشنز قوية جدا، وعندنا الساعة 1 انترناشونال فاكولتي من اليوروبيان سايتو كارديولوجي على الكارديو انكولوجي وعلى الايمجينج فيوم مليان. فان شاء الله يعني اليوم يمشي زي امبارح ان شاء الله. كان يوم ناجح جدا جدا. فبرحب بحضراتكم، وسيب بقى الدكتور سامح والدكتور حسام يبتدوا السيشن الاولاني. شكرا.
Now Professor Rosano will give us a very important lecture about the 4 pillars of treatment of heart failure. Which drug to start with?
This is my declaration of interest, and we know that in the past 4 or 5 years we had very significant improvements in the treatment of heart failure with very significant trials. They've shown efficacy, and these are specifically the SGLT2 inhibitors. And if we look at DAPA-HF and EMPEROR reduced, now we can seemingly there's a similar reduction of 25% in mortality and morbidity, but in reality, DAPA-HF, apart from the reduction of combined endpoint, was also effective in not only reducing hospitalizations for heart failure, but significantly reducing cardiovascular death and death from any cause. And this effect on the death from any cause was also mirrored by the effect on overall mortality that was reduced by 30% in DAPA-CKD. So the SGLT2 inhibitors, without any doubt, are central for treatment of our patients, and especially after the results of the SOLOIST WHF that demonstrated that in patients who are hospitalized for heart failure, in the initiation of sotagliflozin, that is an SGLT2, SGLT1 inhibitor, is associated with a significant reduction in events. So for these reasons, the SGLT2 inhibitors have been included as class 1A in the list of the 4 foundation therapies that should be used in all patients with heart failure. So the ACE inhibitors, beta blockers, MRA, and dapagliflozin. And in those patients who are still symptomatic despite maximum dose of an ACE inhibitor and elevated NT-proBNP levels, then the sacubitril valsartan may be used. Now, we know that there's a clear indication to have in all patients with heart failure the 4 therapies that should be started, must be started at any encounter with patients with heart failure, being that at discharge, when it's seen by, they're seen by a nurse, or when they're seen in the outpatient clinic. The problem is that we have to switch our way of thinking, and rather than using the sequencing of guideline-directed medical therapy that may take from 6 to 12 months for a full implementation, we know that we can start all drugs together. One important point, it is very, 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 very rare to see patients without any, they are completely naive. Because even if they come for the first time with heart failure, they're already taking a beta blocker and an ACE inhibitor for some reasons, being that ischemic heart disease, being that hypertension. So we know that we can start the ACE inhibitors and beta blockers together. This comes from the CBIS-3. We also know that we can start the SGLT2 inhibitors without any problem because they don't affect blood pressure and heart rate. And the same is true for the MRAs, because if you can see patients with the MRA with low blood pressure that are started on an MRA, they show after 1 month already an increase in blood pressure. This is due to the fact that there's an improvement in their hemodynamic status. So the myth of a blood pressure reduction with MRAs is not there. I mean, of course, there is a reduction in blood pressure that is observed in those patients with a blood pressure greater than 120 millimeters of mercury. The same is true for the SGLT2 inhibitors. These are data from the DAPA-HF. As you can see, in patients with a blood pressure less than 110 millimeters of mercury at baseline, there was almost no change in blood pressure. This was less than 1 millimeter of mercury at the end of the study. The problem often lies with the beta blockers because it's difficult to get the full dose of a beta blocker. And even in patients with forced up titration, only 25% managed to get to the full dose. But what is important with beta blockers is not the dose we achieve, but the heart rate reduction that we achieve. And this is a meta-analysis of 13 randomized clinical trials with beta blockers in heart failure. And they have demonstrated that what is important is the heart rate reduction, whilst the beta blocker dose was not associated with a reduction in mortality. Of course, when we treat our patients, we have to consider that blood pressure and heart rate are highly affected by most of the hemodynamic agents, mostly beta blockers, ACE inhibitors, ARBs, and ARNI. And so it's a question to decide how to jiggle between the different medications. And it's for this reason that we've used patient profiling in order to give a guidance on how to implement medical therapy. What the HFA suggests is that we need to start with all the 4 foundation therapies together, and diuretics if indicated because of congestion, and then up-titrate beta blockers or the ACE inhibitors or ARNI according to heart rate, blood pressure, renal function, and also sometimes regarding renal function, we have to be wary for the use of the MRAs. So, for example, in a patient like this with a blood pressure less than 90 over 60 and heart rate between 60 and 70, if patients are on the 4 foundation therapy, there's beta blocker shouldn't be increased, or they may even be decreased and then added, and then used in combination with ivabradine, and the ACE inhibitors also, if the hypotension is symptomatic, should be used at very low dose. In another patient that is similar, there is the one with low blood pressure and low heart rate. You can see that you need to reduce the dose of the beta blocker, maybe use it in combination with ivabradine again. Once you have fully implemented to the maximum tolerated dose for that individual, then it's important to use and add the class 2 recommended drugs. Of course, if that patient is in atrial fibrillation, there's class 1A for the anticoagulants. But if they have, for example, repeated hospitalizations, then vericiguat can be a good option. That is for the implementation of the 4 foundation therapies. So there's no question they should be started all together and then up-titrated according to patient profiles. Regarding MREF and PEF, we gave just a light recommendation when in the guidelines, the class 2B recommendation for MREF, no indication to any class for PEF, and that was last year. Then since last year, then a lot of things have changed. And we had the publication of Emperor Preserved first last year and Deliver this year at the European Society of Cardiology meeting that demonstrated that these drugs are effective in reducing mortality and hospitalization, reducing mortality and hospitalizations for heart failure. So what we do what we have to do in patients with PEF, of course, all patients should be started on either dapagliflozin and empagliflozin, and then we need to look at for the comorbidities and use for each comorbidity the medications have been proven to be effective and reduce mortality in those subgroups. So, for example, in patients with arterial hypertension, we know that indapamide reduces the occurrence of heart failure and the hospitalizations for heart failure as the MRAs or the ARNI. In patients who are obese, semaglutide is very effective in weight loss and has added cardiovascular benefit. If there is iron deficiency, ferric carboxymaltose can be an option. And in patients with COPD, the use of LAMA-LABA and the use of beta blockers, and so on and so forth. So in conclusion, the guidelines suggest a fast implementation of the 4 foundation therapies, and the up-titration shouldn't be done according to the stepwise approach. They should be started together, simultaneously, at discharge or at any encounter with patients with heart failure, and the up-titration should be based on the patient profiles rather than to the target dose. So that is for PEF. In a PEF, then the SGLT2 inhibitor should be started in all patients, and then the additional interventions should be considered according to age, sex, BMI, presence of type 2 diabetes mellitus, hypertension, COPD, and all the relevant comorbidities. Thank you very much.
We'll postpone the discussion at the end of the session. Now we'll go to the second lecture. Professor Wael Kilani, Professor of Cardiology in Ain Shams University. He will speak about SGLT2 inhibitors, evidence across the spectrum of heart failure.
شكرا دكتور حسام. بسم الله الرحمن الرحيم. Today we are going to talk about the SGLT2 inhibitors, the marvelous molecules that's showing us evidence every day across the spectrum of heart failure. Two competing molecules giving us evidence in every study it's put in. Heart failure mortality is high. We know that it's 50% every 5 years. And the problem is hospitalization is also there. Every now and then the patient gets in the hospital, and when he gets out, he does not have the same quality of life. And also the mortality increases. We know that the diagnostic algorithm, according to the ESC in 2021, starts with suspected heart failure with symptoms and signs, and then N-terminal proBNP. If it's approaching these limits, then you do echocardiography, and if you find abnormal findings, you classify patients as HFpEF. If it's more than 50% the ejection fraction, heart failure with mildly reduced ejection fraction before 40 and 50, and less than 40, it's HFrEF. And if you don't have any of these things positive, so you search for another cause of dyspnea. We'll take you back in history. In the past, cardiologists and hepatologists used to make research in separate islands. Every group makes research by himself, not attending or taking attention to the other group. So we see that insulin, DPP-4, GLP-1, nobody noticed that the drugs used for diabetes is important or is harming the heart. Tell the group of TZDs when they started to notice that the bioglitazone use increased the incidence of heart failure. And the drug had bad reputation, and this is the feeling of the company at that time. Starting from this point on, any drug for diabetes has to have an endpoint regarding the cardiovascular safety. And now comes the role of the phenomenal molecules SGLT2 inhibitors. The story starts with the IMPA-REG. In 2015, 7,000 diabetic patients giving placebo versus empagliflozin as an anti-diabetic treatment. Look at what they found. The primary outcome was 3-point MACE, 14% reduction in the occurrence of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke. Now the drug treats diabetes and decreases the cardiovascular events. Cardiovascular death, 18%, hospitalization for heart failure, 35%. This is for the empagliflozin. Regarding the DAPA, the same happened. We told you that they are two competing horses. So when the IMPA did the trial, the DAPA did nearly the same. 17,000 patients with diabetes, patients with established cardiovascular disease, meaning secondary prevention, or with risk factors for cardiac disease, which is primary prevention. DAPA versus placebo, follow up for 5 years, and let's see what happened. Also, heart failure hospitalization, cardiovascular death decreased by 17%. And this is the summary of both trials. The IMPA found here mortality benefit. Well, the DAPA didn't find mortality benefit, but cardiovascular death, hospitalization, and hospitalization as a secondary endpoint was better in the group of diabetics who received DAPA or IMPA. So they started to feel that the molecule is multitask. It can do more than one job. It's an anti-diabetic treatment, and also it can help in heart failure, or at that time in patients at risk of heart failure, because diabetic patients, of course, are at higher risk of heart failure. So you can put it in the pre-clinical heart failure, or patients who are at risk of heart failure. Then this molecule started a new career. With the DAPA-HF, in 2019, 4,000 patients, diabetic or non-diabetic. Now, the molecule is not treated with as an anti-diabetic drug. Now, it is used as an anti-failure drug. Diabetic or non-diabetic, ejection fraction less than 40%, elevated BNP. So this is the patients with HFrEF, with or without diabetes. Forget about the drug as to be used as an anti-diabetic. It's now used as an anti-failure because it's used in diabetic or non-diabetic. And they are giving dapagliflozin plus standard care, of course, versus placebo plus standard care. Look what they found. Cardiovascular death and heart failure hospitalization, urgent heart failure visits decreased 26%, cardiovascular mortality 18%, worsening of heart failure events 30%. So it did very well here also. And the quality of life, of course, improved. And then the DAPA was proven in heart failure, so the IMPA also does a trial. The EMPEROR Reduced trial in 2020, the same. Patients, 3,000 patients, ejection fraction less than 40%, IMPA versus placebo, the same study design nearly. And the primary endpoint was relative risk reduction 25%, cardiovascular death hospitalization, and total hospitalization for heart failure was also decreased by 30%. So the molecule is rising like a rocket. And it found itself, it could find itself a place as a class 1A for treatment of heart failure. As we just heard, that it's one of the 4 pillars together with the ACE-ARNI, beta blockers, MRAs, and here the SGLT2 inhibitors. And anti-diabetic drugs coming in the heart failure management regimen as class 1A from the first shot. Okay. What about the American guidelines? Also, it's put as class 1A, as we can see. ARNI, beta blockers, MRAs, and SGLT2, and of course, diuretics. So now we have evidence that if there is preclinical stage of heart failure, like we said, DECLARE, IMPA-REG, and then the clinical stage of heart failure, DAPA, heart failure, and EMPEROR Reduced. So now it's proven in high-risk patients with diabetes, and it's proven for heart failure with reduced ejection fraction. Both molecules by nearly the same data. And now this is the feeling of the company producing these 2 molecules. Now we come to the dark cave of cardiology, the HFpEF. The HFpEF patients presented with dyspnea, you do an echo, you find that the ejection fraction is normal. And you give medications, and the patient comes complaining of the same symptoms every time. I'm not improving, I'm having dyspnea. I'm not improving, I'm having this. And you cannot do anything. And the guidelines recommended at that time only diuretics. Let's see what happened with these molecules in this subset of patients. I'm sorry. The EMPEROR Preserved 2020, patients with ejection fraction more than 40%, 6,000 patients, randomized to IMPA versus placebo. What did they found? Patients, ejection fraction more than 40%, BNP is high with structural change of the heart. They defined heart failure as preserved ejection fraction by this simple criteria. Patients were diabetics or non-diabetics. Half the patients were non-diabetics. So again, it's not used an anti-diabetic treatment. And the patients were taking these medications that were at that time tried for HFpEF. What did they find? They found significant reduction in the composite endpoint of cardiovascular death and hospitalization, but take care, mortality did not improve by itself. So when they collected mortality and hospitalization, the outcome was okay with significant p-value, but mortality by itself alone as a secondary endpoint was not significant. Can you imagine that this happened in this miserable subset of patients? Since early months, the curves separate since early after administration of the drug. What about hospitalization? 25% reduction of hospitalization. And as we can see here, that the primary composite endpoint was significant, but heart failure hospitalization was significant, but cardiovascular mortality was not. Now the IMPA is proven in heart failure preserved ejection fraction. What about the DAPA? They also made a trial that was recently published, dapagliflozin in heart failure. This is called the DELIVER trial. The same idea, adults more than 40 years, heart failure preserved ejection fraction defined as ejection fraction more than 40, class 2 to 4, elevated BNP. The same idea. DAPA versus placebo. What did they find? 6,000 patients. Recently published in the European Society of Cardiology meeting in August. And the primary endpoint, cardiovascular death or worsening of heart failure, was significantly better in patients with dapagliflozin as a treatment of heart failure preserved ejection fraction. Again, hospitalization was reduced significantly, and again, mortality was not improved. But these are good news, because these patients did not have any other option. So now we can give them a treatment that decreases symptoms and improves hospitalization. Thanks God. Regarding the American guidelines, it has put the patient with HFpEF, diuretics, and then SGLT2 at the second step. You can put ARNI, MRAs, ARS, but the lower indication 2B, but 2A is SGLT2 for the first time. If we collect this information regarding the IMPA, if we put the IMPRA reduced, checking patients less than 40% ejection fraction, and the IMPRA preserved checking patients more than 40% ejection fraction, you can simply note that across the range of ejection fraction, any patient with dyspnea, you can treat with SGLT2. Yes? Because before 40%, the IMPRA reduced gave us good evidence, and after 40% or more than 40%, the IMPRA preserved gave us also good evidence. What about the DAPA? The same. In October 2022, 1 month ago, effect of dapagliflozin on cause-specific mortality in patients with heart failure across the spectrum of ejection fraction. The same idea, they collected the DAPA heart failure before less than 40% and the DELIVER more than 40%, and it found 40% lower risk of cardiovascular death regardless of ejection fraction. So still, whenever you have a patient with dyspnea, whatever the ejection fraction, you can use SGLT2 inhibitors. And it's also recommended in guidelines. So the two competing horses are still making success every day. And recently, in the chronic kidney disease, we have the DAPA kidney and the trial for the IMPA, I don't recall the name. The IMPA kidney also. So now it's proven for diabetics, non-diabetic patients with chronic kidney disease. So it has proof for patients with diabetes at high risk of cardiovascular disease, patients with HFrEF, patients with HFpEF, patients with chronic kidney disease. And recently I heard that it's giving us some evidence in non-alcoholic liver disease, fatty liver disease. This is a very strange molecule. So we are waiting for more success for this group of molecules. And it's opening door for patients that in the past had no treatment or had no hope. Thank you very much.
طب يعني few questions كده opening اي حد عاوز يسال اسئله؟
Thank you very much, Professor Wael. Excellent presentation.
Thank you, Dr.
So from day one, once we diagnose patients with heart failure, don't wait for echocardiography, and you can start SGLT2 inhibitors.
Yes.
This is the message
Yes,
that
yes.
the consistent benefit of SGLT2 inhibitors is proved with different ejection fractions.
Yes, this is true.
And the interesting that in the liver study that the benefit of the drug was not attenuated even if the ejection fraction more than 60%,
Yes, true.
compared with
With the IMPA.
other IMPA, and also in Paragon HF trial with the use of circulatory valsartan.
Yes, try.
So I think this is a very important message.
Very true.
That the,
You can start it regardless of the ejection fraction.
وائل, thank you very much for the excellent presentation as usual. يعني الحقيقة برضو بحيي مجدي جدا على المؤتمر الجميل والفيري هاي كواليتي ساينس اللي احنا بنسمعه النهارده واختياره بعناية السبيكرز اللي منهم انت يا وائل يعني.
Thank you.
الحقيقة انت أشرت إلى حاجتين مهمين. طبعا احنا we know the issue of the 4 pillars for heart failure, but now they are also talking about the 3 pillars for kidney disease.
Yes.
اللي انت اضفت لهم دلوقتي اللي هم بنتكلم دايما على مجموعه الراس بلوكيد، بنتكلم على الاس جي ال 2 انهبيتورز، ويمكن النون ستيرويدال فينيرينول ان بارتيكولر. فاحنا دلوقتي بعد ما كنا قاعدين يعني مكتوفي الايدي،
صحيح.
our يعني armamentarium for treatment of patients was quite limited. Now we are having clear evidence for medications that can really change the lives and the prognosis for our patients.
True.
محاضرة جميلة. أنا قلت بس أقول التعليق ده.
Thank you, Dr. Hisham.
كده يعني ننتقل للمحاضرة الأخيرة في السيشن دي قبل الصلاة، يعني دكتور مجدي عبد الحميد. دكتور مجدي عبد الحميد رئيس المؤتمر. فبراحته يعني نص ساعة، ساعة إلا ربع.
لا لا لا.
ادينا قاعدين.
I think the أول meeting اتقال فيه الإسكيميا extend trial. I don't remember that this presentation was given before. So let us to see the trial which was presented in the American Heart Association 2 weeks ago, the ischemia extend. And we know that the background that 5 years ago, the rationale for the study that to compare the conservative treatment versus invasive strategy in patients with chronic coronary artery disease. Is there a difference between invasive strategy and the conservative strategy? Because we know that the primary goals of treatment in chronic coronary disease is to improve survival and to improve quality of life. So the primary outcome of the study, ischemia trial, major adverse events, which include myocardial infarction, heart failure, hospitalization for unstable angina, resuscitated from cardiac arrest. And the secondary outcome, which was very important, is the quality of life, the relief of angina. So the study at that time, the median duration of follow-up was 3.2 years. And we know that the results of this study proved that there was no significant difference in mortality between conservative and invasive strategy. And the results also confirmed that invasive strategy was associated with high incidence of peri-operative, peri-procedure myocardial infarction, while the conservative strategy after 4 years was associated with high incidence of spontaneous myocardial infarction. But mortality benefit was not proved when comparing conservative versus invasive strategy. Again, this is the original follow-up, which was 3.2 years median follow-up duration, that there is no significant difference in all-cause death as well as cardiovascular death. And interestingly, that non-cardiovascular death was high with the invasive strategy, and this was statistically significant. So the objective of Ischemia Extend study is to assess whether there are between-group differences, looking mainly in the Ischemia Extend for mortality, which includes all-cause mortality, cardiovascular mortality, and non-cardiovascular mortality. This is the main objective of Ischemia Extend study. So the duration of follow-up here is the median follow-up duration of 5.7 years. So the initial ischemia trial, the median follow-up duration was 3.2 years, and in ischemia CKD was 2.2 years. But in Ischemia Extend, the duration of follow-up increased to be more than 5 years. And now the study is still ongoing. The aim is to look for 10 years follow-up, like STITCH trial. If you remember a STITCH trial, the data of 10 years have been published before, because we might see more benefit in favor for the invasive strategy compared with conservative strategy with extended duration of follow-up up to 10 years. So the inclusion criteria, we know that patients with moderate to severe ischemia, exclusion, ejection fraction less than 35%, recent acute coronary syndrome within 2 months, unacceptable angina, left main more than 50%. Those patients were excluded from ischemia trial. We are not talking about left main. We are not talking about patients with recent history of ACS. We are not talking about patients with ejection fraction less than 35%, or patients who have recurrent attacks of angina, unacceptable angina. Those patients were excluded from the ischemia trial. So we know that this study included more than 5,000 patients, and the sensitivity of site-determined cardiovascular death was 91%, and the positive predictive value was 96%. The statistical analysis of this study is very complicated, because they were looking for each parameter to look for if there is a significant difference between both arms or not. So there is a details in the statistical analysis, which I think need an expert in statistics to tell us in details about this extensive statistical analysis for a landmark trial like ischemia trial, which included 5,179 patients. This is the randomization of the study, invasive arm and the conservative arm. And in the conservative arm, they are receiving optimal medical treatment. And by optimal medical treatment, we mean LDL reduction. But this study was 2014. The LDL at that time, the target was less than 70 milligram per deciliter. Now it's less than 55, you know. So optimal medical treatment is mandatory for patients included in the study, titration of the drugs to achieve the target goal for LDL, blood pressure, antiplatelets, etc. So when comparing both arms, the invasive arm versus the conservative arm, looking for the primary endpoint and secondary endpoints, the mortality in the first analysis for the invasive arm included 145 patients died and 144 in the conservative arm. And this was not statistically significant. The baseline characteristics of patients included in the study, you can see that the age was 64, the mean age. The diabetes, 42%. The mean ejection fraction, 60%. Of course, those patients are symptomatic. History of angina was reported in 90% of patients included in the study. So mortality was 289 after 3.2 years median follow-up. When extending the duration of follow-up to 5.7 years, the mortality was 268. So the total death at 5.7 years from 5,000 patients included in the study was 557 patients. So look for the statistical analysis to compare between both arms, conservative versus invasive strategy, regarding all-cause death, all-cause mortality. And you can appreciate that this was not statistically significant. Mortality was not significant in favor of conservative or in favor of invasive strategy. 7-year rates, 13.4 versus 12.7%. Look for cardiovascular death. In cardiovascular death, interestingly, they observed, you can appreciate the separation of the two curves after 5 years. And in this case, this indicates that the invasive arm was associated with a statistically significant reduction in cardiovascular death. 8.6% with the conservative arm versus 6.4% in the invasive arm. This is the first interesting observation which is significant in favor for the invasive strategy compared with the conservative strategy. What about non-cardiovascular death? And this is also very interesting, that non-cardiovascular death was high in patients who were subjected to invasive strategy compared with conservative strategy. 5.6% with the invasive strategy compared with 4.4% in the conservative strategy. Very interesting observation, and they did not demonstrate why non-cardiovascular death was high in the invasive arm. They postulated that this could be due to development of malignancy or infection, but until now, there is no strong explanation for why non-cardiovascular death was high with the invasive arm. The subgroup analysis, there was no heterogeneity when they are comparing different variables to look for if there is a significant difference between both arms regarding the severity of ischemia, regarding the number of diseased coronary arteries, regarding the guideline-directed medical therapy, regarding the percentage of stenosis of LAD, multivessel disease or not. There is no interaction between initial strategy assignments and pre-specified subgroups for all-cause death, cardiovascular death, and non-cardiovascular death. And if you look for this sub-analysis for patients with multivessel disease, 2 vessels or more, defined by stenosis more than 70%, and again, whether the patient has multivessel disease or not, the statistical significance was not proved, so all-cause death was not different when they compared both conservative and invasive strategy based on the presence or absence of multivessel disease. And again, multivessel disease defined by stenosis more than 70%, but looking for cardiovascular death, not all-cause death. And again, the same, there was no statistically significant difference. While non-cardiovascular death, according to the multivessel disease or not, we can appreciate that non-cardiovascular death was high with patients who were subjected to invasive strategy. This is the same. Some limitations of ischemia extent was mentioned here in this slide. So I'd like to focus on the conclusion of this study, because this is a long-term follow-up up to 5.7 years. And again, compared with the initial results that have been presented 3 years ago, 2019, that comparing invasive and conservative strategy for patients with chronic coronary artery disease, there was no difference in all-cause mortality, with nearly twice the number of deaths, up to 557. But interestingly, there was a lower risk of cardiovascular mortality in favor for the invasive arm, while a high risk of non-cardiovascular mortality with the invasive strategy compared with the conservative strategy. So the implication of this study is important, that we are dealing with patients in the daily practice having chronic coronary artery disease. So whether we will follow the conservative strategy or invasive strategy, this depends on the angina, the quality of life. The decision-making should be individualized, and shared decision-making between the physician and the patient is very important to decide which strategy is beneficial for the patients. So this study was published in the Circulation. Again, there was no difference in all-cause mortality with initial invasive versus conservative strategy. However, invasive strategy was associated with lower risk of cardiovascular mortality, while conservative strategy is better regarding non-cardiovascular mortality at a duration of 5.7 years. This is an interesting algorithm was presented before, how to manage patients with stable coronary artery disease having significant coronary artery disease more than 50%. You will give a medical treatment to intensify guideline-directed medical therapy, cardiovascular prevention, anti-anginal therapy. Do CT coronary angiography to rule out left main, because if you have a left main disease, these patients should be subjected to revascularization. You have many non-invasive tools to assess the degree of ischemia: CMR, PET, SPECT, stress echo, and all these non-invasive tools can identify the degree of ischemia, severe ischemia or not, because if patients is asymptomatic and doing well with optimal medical treatment, so you can continue medical treatment. However, if the patients have still refractory angina, this patient should be referred to revascularization. And of course, mild ischemia should be treated medically, and if no ischemia, search for alternative etiology. And we are proud to be part of the ischemia trial as the Cairo University site included in this important trial. Thank you for your attention.
شكرا دكتور مجدي.
Still, we are waiting the sub-analysis, because this is very important observation. We don't know why the non-cardiovascular mortality is high in patients with invasive strategy.
هو published ولا هي just presented in age؟
circulation.
published. المفروض لو published المفروض يكونوا يطلعوا
لسه sub analysis بيبقى في another study.
دكتور هشام
another
اتفضل.
publication.
مجدي يعني thank you very much for the excellent presentation. يعني مش حاجة غريبة يعني طبعا ده المتعودين عليه. الحقيقة you are showing a very interesting study لأنها probably it will be changing the guidelines. طبعا في ناس هتبقى معترضة وانت حطيت سلايد كده يعني واضح انه وده منطقي بالذات الانفيزيف كارديولوجيستس والتانيين will be and just looking to the thing بنظر انا الحقيقه اللي شويه مستصعبه دلوقتي هو what am I going to say to the patients. يعني هيجي لي عيان يقول لي يعني انا امبارح فعلا I was doing a case وبعدين الراجل عنده 80% single vessel قال لي لازم اعمل. انا قلت له دلوقتي 80% نعمل لك دعامه. فقال لي يعني ولازم. in terms of the ischemia trial what am I going to say. انت لو عملت او ما عملتش هتعيش ال7 سنين mortality او ال5 سنين 5.7 year mortality is almost the same. بس هو برضه having said that الترايل مبينه كام نقطه مهمه جدا. number 1 انه symptoms did improve in the arm of invasive strategy. This is number 1. Number 2 ودي بالنسبة لي الأهم that cardiovascular mortality was significantly reduced in the invasive strategy. المجموعة الثانية اللي ما عملتش non-cardiovascular mortality was lower بس سبب non-cardiovascular mortality كان mainly two issues. One of them was malignancy والتاني كان infections. What are you going to say to the patient لما يجي يسألك؟
Yesterday we had an extensive discussion. Yesterday first session you remember.
على فكرة برضو بالنسبة first day الناس كلها مستمتعة باللايف ترانسميشن اللي انتوا عاملينه وقاعدين بيتفرجوا. يمكن الحضور هنا مش كتير بس الحضور على النت عالي جدا. And they are very very happy of the discussions that were ongoing. يعني.
لأن احنا امبارح قعدنا تقريبا ساعة كاملة نتناقش في the same question, the same patient, single vessel disease أو multi vessel disease, what to do, conservative or PCI. And we have heard about this issue a lot of opinions. One in favor of ischemia, supporting ischemia very strongly, and the other, no, it should be revascularized. So still, this is a debatable issue. And this patient specifically, if this patient has an angina or not, optimal medical treatment and responding to treatment or not, quality of life, and then discussion with the patient about the benefit. If he is symptomatic and cannot be controlled with medical treatment, so this patient is for PCI. But if the patient is doing well and he is nearly asymptomatic on proper maximal medical treatment, we can go with ischemia and follow up for this patient. So still, I think the 10 years might change the whole concept, what to do for patients who is doing well on medical treatment. Yesterday, I presented patient multi-vessel disease since 2009. So 13 years on medical treatment, and he's doing well, no angina, and he's coming with a lot of coronary angiographies. LED, proximal mid-segment, ramus, obtuse marginal, RCA. And he's asking for opinion, what to do. I'm doing well on medical treatment. Should I go to CABG, as I was told before? What do you think?
Do you think that the guidelines should change in the mindset of talking about symptom-directed management instead of ischemia-directed? Well, should we be combining both? No, definitely putting symptoms in the context is something important.
Yes. I think symptoms guided is very important. So it's an individualized treatment, not every patient like the same. And the new guidelines will be after 2 years, not the next year, 2024. We have a new guidelines for chronic coronary syndrome. And I think the results of ischemia might change the recommendations of PCI in chronic coronary artery disease.
دكتور مجدي محاضرة رائعة كالعادة ودايما يعني بتجيب لنا كل حاجة جديدة. يعني عندي دايما تساؤل، يمكن احنا عشان برضو حتة الاستادي ديزاينز وكده، كنت عايز اعرف من حضرتك العيانين اللي هم في الحاجات اللي فيها فولو اب بالشكل ده. دلوقتي هم قارنوا المجموعة دي من العيانين اللي ما عندوش اكيوت كوروناري سيندروم، اللي زي ما حضرتك قلت اللي ما عندوش ليفت مين ايجكشن فراكشن كويس وغيره وغيره، وراحوا حاطينهم على انفيزيف فيرسس كونزرفتيف وعملوا الترايل. الفولو اب بقى في كروس اوفر قد ايه؟ يعني كان من مجموعه الميديكال راحوا ناحيه الانفيزيف، وهل اتحسبوا على الانفيزيف ات ذات تايم ولا اتحسبوا على الميديكال؟ ممكن حضرتك توضح لنا الحته دي؟
كروس اوفر 23% of the
راحوا من الميديكال ارم للانفيزيف.
But why? Because they have angina not responding to medical treatment.
لما بقى بيجوا يحسبوا الاوتكم بيحسبوه على الانتنشن تو تريت من الاول ولا بيحسبوه على الانفيزيف؟
لا
فاهم قصدي؟
كومبير الانفيزيف ارم للكونسرفتيف ارم.
يعني هو كده العيان كانه بيروح بيسيب الجروب ده بيروح للجروب الثاني، وهم بيعملوا statistics تاني على ان ده ناقص 25% وده زاد 25%.
صح.
انا فاهم صح؟
وهو اهم حاجه في الاستادي دي كان الاوبتيمال ميديكال تريتمنت. لو عيان مش receiving optimal medical treatment cannot be يعني considered, can be excluded. لو هو ال LDL بتاعه مش واصل للتارجت، blood pressure less than 140/90, receiving guideline directed medical therapy, this is mandatory في العيانين عشان نقول ان ده receiving the proper treatment في الconservative arm.
طيب حاجه كمان، حضرتك طبعا في الترايل اللي هي الريفايفد ترايل اللي عملوا فيها العيانين اللي عندهم left ventricular dysfunction وعندهم evidence of viability لفور segments، كان فيهم 19% عندهم left main disease. دي بقى يعني خطوه اجرأ شويه. فمشى العيانين دول على medical treatment versus revascularization and the results were the same، يعني ما كانش في فرق. طب ناخد دي ازاي؟ هو ده بقى كان اجرأ من كده، عنده LV dysfunction و19% عندهم left main disease، ومع ذلك الانسيدنس اوف كارديوفاسكولار مورتاليتي كانت هي سيمتوماتولوجي وايز طبعا الريفاسكولاريزيشن كان احسن، ولكن يعني الحته بتاعت ان انا تو ريفاسكولارايز في العيانين دول، طب هاو تو ديسايد؟ ده سؤال تاني اصعب. يعني عنده ليفت مين وال في ديسفانكشن وفايبل ومفيش ايفيدنس اوف مورتاليتي بنفيت، يعني نحط دول ازاي مع بعض؟ يعني الموضوع انا شايفه فيري كومبلكس.
الريفايف طبعا النمبر اوف بيشنتس مش
700 كانوا مش كتير.
طيب.
صحيح
ما نقدرش نقارنه باسكيميا اللي هي 5000 وشويه.
مفهوم.
اولا الريفايف will be presented today بالدكتور احمد سمير في الاخر سيشن على في الكلينيكال ترايلز. فيعني I think we might see يعني
برضه هيبقى في ديبيت رهيب.
لان هي it's very interesting study بس لو if you remember الستيتش ترايل ال 10 years ورت irrespective of the presence or absence of viable myocardium, revascularization was better compared with conservative treatment. So a lot of issues still.
هو زي ما حضرتك قلت هي it should be personalized ويخش فيها الديسيجن المريض مع الدكتور مع ال LV function مع الاناتومي عامل ازاي.
صح.
It's really complex. Sometimes you don't know what to do. صحيح.
دكتورة اتفضلي حضرتك في سؤال.
Thank you, Dr. Magdi, for this elegant and very important and debates will be raised too much because, as doctor said, that in patients with in ischemia trial, 35% of patients underwent conservative treatment. They both referred to in revascularization during the study. At the same time, patients assigned for revascularization, 1/5 of them, when do catheterization, they have normal coronaries and no need for revascularization. And I don't, my question, if they refer to the medications, to the group of medication, so there is bias between the results. For the same time in diagnosis, first, in the diagnosis of severity of coronary artery disease, they included patients with proximal LAD and the patient with more than 70% stenosis. At the same time, they included patients if they have more than 2 vessels with 50% stenosis, they included in the severity to be maybe 4 or 5, not 6 as the others. So the heterogeneity of diagnosis, and at the same time, they mentioned that the coronary angiography that done for the patients is done only for 67% of patients. At the same time, about 33% of them cannot be interpretable because abnormality of views. So we are now biased. what to do? As the same questions again. The selection of patients, they are not the same, different category, and the diagnosis differ. At the same time, patients undergo conservative treatment, refer to revascularization, and patients assigned for revascularization found nothing in their vessels. So how to trust the results? This, I'm not. Okay, yes.
سؤال. بص حضرتك الاستادي دي well designed study بمعنى ايه؟ patients presenting with stable angina. اول حاجه بتعمل له myocardial perfusion imaging او فيتامين ستريس ايكو to look for moderate to severe ischemia. الداتا دي بتروح للكور لاب. الكور لاب بيعمل اناليسيس، ناس اكسبرتس، دي امريكان ستادي NIH، لقى moderate severe ischemia، يبقى البيشنت ده كان بي انكلودد، بس هيروح يعمل سي تي كوروناري انجيوجرافي. يعمل سي تي كوروناري انجيوجرافي، يروح للكور لاب يعمل اناليسيس. ليفت مين 50% or more excluded، روح يعمل ريفاسكولاريزيشن will not be included in the study. مفيش ليفت مين، يبقى ده candidate for the study. عنده انجينا وعنده moderate severe ischemia بالايمجنج وعنده سي تي كوروناري انجيوجرافي، ما عندوش ليفت مين. بعد كده الراندمايزيشن يبتدي كونسرفتيف ارم. السب اناليسيس بقى اللي كان انترستنج في سواء في الاول ترايل او في الاكستندد، ان مفيش فرق وات ايفر بقى اسكيميا سيفير ولا لا، ال اي دي بروكسيمال ولا لا، مالتي فيزل ولا مش مالتي فيزل، ايجكشن فراكشن طبعا من الاول خالص هو كله above 35%. فالقصد اقول ان الاستادي دي ويل ديزايند بكور لاب باناليسيس بناس اكسبرتس، مفيش اي بايس في الاستادي، والفولو اب فيري كلوز مونيتورنج وفيري كلوز فولو اب للتارجت ال دي ال والبلاد بريشر. فالاستادي ما فيهاش يعني ليميتيشنز تخلي الريزلتس مشكوك فيها.
انا بس عندي كومنت. انا pending the changing guidelines الاسكيميا اكستندد دي هتأثر in my practice as follows. أنا I do believe إن أنا I will not be pressurizing my patients having same criteria for entry into the study regarding لازم يعمل قسطرة و invasive strategy لو هو مش عايز. لأن أنا في النهاية I will be giving him more space لأن أنا I'm having more evidence regarding relative safety for going on a medical treatment strategy. ودايما هبقى حاطط في بالي فكرة الكروس اوفر أو إن أنا to go to invasive strategy لو العيان is showing going to acute coronary, deteriorating in LV function, having significant symptoms, all this in mind. فما أعرفش ده fair ولا لأ، بس I think so yeah.
I think you have to explain to the patient.
صعوبة الإكسبلانيشن.
waiting ده قد يعرضه برضه إنه يجي له أكيد خلاص.
ما هو this is not true.
وجاله مثلا بتاع 80% بتاع امبارح ده اللي عملته، لو ما عملتلوش وبعد 6 شهور جاله أكيد انفاركشن. يعني طول ما كنت
أنت عارف يا سامح، لا أنت عارف يا سامح the problem, the real problem إنه till now we do not have real evidence that invasive strategy will significantly reduce myocardial infarctions. عندنا some evidence that it may reduce, but no conclusive word.
شكرا دكتور مجدي. دلوقتي